Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Calafella, also a Melbourne-based GP.
In today's podcast, we're going to talk about our approach to a skin check, what we do, why we do it, what instruments we use. But before we go any further, I'll remind you that a podcast can't replace a consultation with your own healthcare professional. Dr Moz.
We have got a lot to talk about today, actually, Dr. Anne. So we're kind of into episode 3, I guess, of our sort of 3-part series around skin cancer, although I'm sure we'll talk a lot more about skin cancer in the future. And so this episode, we're going to focus a little bit about what happens when you come into the consultation room and what we're actually doing, what we're chatting about, what we're actually specifically assessing you for, and how we make decisions that are shared with the patients on a regular basis. So I guess the first thing that we do when you walk in is talk, isn't it, Dr. Anne?
It is indeed. We want to assess your risk, which will be along the lines of the things we talked about in the last couple of podcasts. And we'll also find out if you've got any specific concerns, because you're an important part of the team. The history of change, as we touched on in previous episodes, is super important, and only you can tell us if it's the first time we've seen you, whether a spot is changing or not.
Yeah, absolutely. And this is often a pretty confronting bit if your sun protection is poor, because we're going to drill down and find out exactly how good you are at sort of putting sunscreen on and avoiding the sun. So please tell us the truth. Because it does make a difference, doesn't it, Dr. Anne?
It does, and you should be prepared that we're going to check you top to toe. So we'll be looking through your scalp, looking through your hair so we can see your scalp. We'll be checking between your fingers and toes, looking at your nails, checking the soles of your feet, palms of your hands. So be prepared for a rather thorough examination. And on that note, we actually quite like you to think about the undies that you wear to our appointment, because certainly if you're coming for a full skin check, we prefer the kind of less is more approach, because skin lesions can hide under undies. So we will be, if you're a girl, hoping for you to at least unhook your bra, not remove it. And boy or girl, we'll be looking to move your undies to one side or another to have a careful look at your buttock skin and your groin skin, and just to be prepared for
Absolutely,
that.
because even though they're not sun-exposed areas, like we've sort of talked about, you can still make melanoma in those spots. And so you can make melanoma anywhere where you can make pigment. And so it's probably worth having a little look anywhere where you can make pigment. And so that's why we look in your mouth and in your eyes and in your scalp, and also underneath underwear and bras. So yeah, absolutely. And I guess as part of that examination, Dr. Anne, both you and I wield an additional device, which many other doctors in Australia do.
Yep.
What can you tell us about that device? Yeah, that's the one.
Yeah. So the thing that we can do that you guys just can't is that we can examine your skin spots with an instrument called a dermatoscope. I'm showing one to the camera right now, and it'll be a familiar sight to anyone who's seen either of us for a spot check or a skin check at any point. And this is an amazing little optical instrument that helps us see into your skin. It's a little handheld microscope. It eliminates surface reflection. We can actually see up to 1 millimeter into the skin, which probably doesn't sound like a lot, but that actually lets us to see down to the deep dermis. To understand, the skin has 3 layers. We've got the epidermis, the really superficial layer, then the dermis, and then next down we're into fat. And almost all skin cancers will be in the top 2 layers, and we can see well into the second one with this little device. So it's pretty awesome.
It is very cool. And I think, when you're sort of talking about what's the point, I think the reality is it means that you can get a lot more information out of, a little brown spot all of a sudden when you can see, quite very remarkable and well-defined sort of features within the spot and how it sort of interacts with the skin. So hopefully there might be some photos flashing up of normal moles or abnormal moles, and you can see how much homework we did trying to find the photos for you over the period of post-production editing, so you can give us some feedback on how our photos look. But yeah, you can see lots of structure and network, and you can see other stuff as well, can't you, Dr. Anne, other than just sort of the pigment? We do get to see other stuff.
Lesions that don't have a lot of pigment, we can see the blood vessels, and particularly for some non-melanoma skin cancers, for the basal cells and squamous cell, the shape that they form and their arrangement can often be a clue to one type of non-melanoma skin cancer over the other. So it's a super interesting and wonderful little tool. Not without my dermatoscope as our mantra. Yeah, definitely.
Absolutely.
I think we can see Sorry, go
Yeah, I
ahead.
was about to say it feels almost like you're going blind without it sometimes, doesn't it? Like we've gotten so used to having these instruments.
And they certainly make diagnostic accuracy a whole heap better. We have some stats in that, Moz. We've always got some stats, yeah.
There's
So
always
for
stats.
pigmented lesions, which was the initial reason that there was an interest in dermatoscopy, for pigmented lesions, how much more accurate does it make people?
I don't know, Dr. Anne.
Oh, you
What do
don't
the numbers
know?
say?
Okay. So, studies have suggested that without a dermatoscope, doctors, including dermatologists, probably will biopsy 30 pigmented lesions for every melanoma. Once
Hmm.
you add in use of a dermatoscope by a person who's trained in interpreting the pictures, that will reduce to around 9 or 10 biopsies for every melanoma. So 20 people have been saved a biopsy just because the doctor's been trained in the use of a dermatoscope. So it's not
And
100%, you'll notice.
yeah, and so just so that you can wrap your head around that number a slightly different way, that means that 30 people walked into a dermatologist or a doctor's office, and the dermatologist or doctor said, "That thing looks odd, I need to remove it." They were wrong 29 times for the one melanoma that they found before they had the handheld dermatoscope. And now it's much closer to there's 9 people being biopsied, and then there's the ninth person is a melanoma. And that's sort of a huge
Mm.
improvement in, the number of things that we're removing. That's a big difference when you think about just those 30 people. It doesn't sound that much, but when you apply that across every doctor in Australia, that's a lot of spots not being cut out, thankfully.
Yeah, and for
Yeah.
context, because you might be thinking, my goodness, even a dermatologist was biopsying 30 lesions for every melanoma. Um, Benign moles outnumber melanoma 2 million to 1. So if we're even down at 30 to 1 proves that the person has training and actually knows what they're doing. But if you can get
Hmm.
from 2 million to 1 down to 9 or 10 to 1, that's actually startling. I think it's important to remember that, yeah.
And maybe this is a good time to detour ever so slightly and talk about sort of our approach to these moles, I guess, because often people get really confused that we want to biopsy things, but part of the conversation is, and I'm pretty sure it hopefully will be a nothing, because we don't always cut things out because we think that they're definitely a cancer. We're often cutting them out for a different reason, aren't we, Dr. Anne?
We're cutting them out because we can't be sure that they're not a cancer. And that's a sort of
Mm.
conversation I tend to have with every patient, that we biopsy them not because it's sure it's a cancer, but because we can't be sure that it isn't. And that's an
Yeah.
important distinction to make. Yeah.
Mm.
It's not
We want to be able to
100%.
look at your moles and say, that one is nothing, that one is nothing, that one is nothing. This one, I cannot be sure that it is nothing. And then we have to make a decision about what we're going to do to
Hmm.
increase that certainty. And so that might be a biopsy, but it might also be looking at it again over a period of time. And we can't
Yeah.
always do that. There are rules around which moles are safe and which moles are unsafe to be monitored. But the idea is that essentially we want to be able to look you in the eye and with a great degree of certainty say this mole is harmless to you or this skin blemish is
Hmm.
harmless to you. Yeah.
Yeah. So the harmless ones are easy. We have a look, we move on. We have a look, we move on. We often say to patients that boring is the best type of skin spot. That you want your doctor to carry on chatting about the weather, their holiday, Christmas, whatever, as they're doing your skin check. But once they're not boring, that's when our decision making kicks in. And it's actually easy for us, if the lesion has a clear clue to malignancy, of which there are 9 published clear clues, because the decision then is easy. We should biopsy the lesion. But it's the ones that
Mm.
are borderline, the ones that are a little bit odd, a little bit
Hmm.
asymmetric, that don't have a clear clue to malignancy. Those are the ones that we
Yeah.
need to make a decision about. And you'll be involved in that decision making.
Absolutely. So you and I both practice fairly patient-centered care, which means we're involving people in our discussions all the time. And like you've said, again, that's a really important distinction. You can have a really boring mole, you can have a really obviously abnormal mole, but then you can also have a mole that's neither boring nor absolutely abnormal. And again, we need to have a little bit of a conversation about those. And again, it'll depend on where it is, how many other cancers you've had, what your hit risk looks like, how abnormal it is. Yeah, so there isn't a one size fits all solution, is there, Dr. Anne?
There isn't. And so even if your mole has a clear clue to malignancy and we are therefore duty bound to biopsy it, it won't always turn out to be a cancer. And that
Hmm.
should be a cause for celebration rather than a cause for the patient to decide that their doctor is clearly an idiot. And I think it's interesting that quite often patients come to us for a skin check for the first time and have maybe had the skin check and a biopsy elsewhere. And not every time, but sometimes people say, well, I had a couple of Moz biopsies, but they turned out to be nothing. And a sort of, and they'll say that with an exasperated sort of rolling eyes thing, like, the doctor wasted my time. And I think it's really interesting, the attitude that compared to perhaps if you look at mammograms or colonoscopies through the bowel cancer screening program, because they're far from 100% either,
I think, like with many things in medicine, it comes down to communication, doesn't it, Dr. Anne? Like, they perhaps didn't have that expectation or sort of game plan communicated to them. And often that lack of communication is what leads to frustration in a huge number of aspects of medicine. I think that's the key thing. So, and that's what we're trying to correct today, hopefully by communicating that to you. You can be less exasperated.
So dermatoscopically suspicious does not mean this is definitely a cancer. It means that it's high risk for being a cancer and we want to biopsy it. And a biopsy is part of the diagnostic process. And if you have a positive bowel cancer screening test and you end up with a colonoscopy, 3% of you will have a cancer and 97% won't. But that 97% are generally relieved and grateful. Similarly, if you have a mammogram through the breast screen program and you go to the follow-up assessment clinic because there's something they're worried about and end up having a biopsy, 20% will have cancer. So that will be 1 person in 5, and 4 people of 5 won't have cancer. And I think we need to think about skin biopsies with the same lens, that in fact the lesion was high risk. Thank the Lord when we did the biopsy, it was a false alarm. Yeah, I think that's what we need to bear in mind. Yeah.
Yep.
What else to say, Dr. Moz?
Well, I was going to say, I think the other thing to think about is we've got one other little trick up our sleeve in our rooms, don't we, Dr. Anne? So we've got the handheld dermatoscope that you've sort of shown the people watching online, the video version of the podcast. But we have another tool that you can't wave around, and it's a digital dermatoscope. So tell us a little bit more about the digital dermatoscope, Dr. Anne.
So the digital dermatoscope is a very similar device, but it's attached to a television screen so that in the first instance, you guys can see what we're looking at, which does make it more fun and interesting for you. We can show you the features that are worrying us, shows the blood vessels, shows the shape, the pigments forming. But while that keeps it fun, makes the experience much nicer and more interesting for you, the important thing is that we can store pictures of the lesion at that point in time. Okay, which means that when we have a lesion which is borderline, doesn't have a clear clue to malignancy, but we think it's a little weird, we can then do an interval review. We can bring you back in 3 months' time, take a new picture and compare today's picture with the new picture side by side and see if there has been any change. And that often is a clue that something is a cancer if it's changing over time, particularly if that change is asymmetric.
And I mean, just the thought alone is pretty exciting. But now actually some of the newer software, like the new software that we've got at Yarra Trail, puts an old shadow of what the old mole used to look like. The software I use at Pascavale does a pretty similar thing as well. And I think the reality is you can pick up on very small, subtle changes that you wouldn't have been able to pick up otherwise without digital dermoscopy. So I think, if you think about 10 years ago or even 15 years ago, before digital dermoscopy was really commonplace, what we would be doing is describing the mole. There's a 3 by 4 millimeter light brown spot with some signs of irregularity, and then we would use some specific terms around the irregularity. And then when we saw you again in 3 months, if it was 3.2 by 4, we wouldn't have picked that because we would have said, well, it's still about 3 by 4. And so I think now it's much easier to pick up on subtle abnormalities over time with a great degree of confidence, which is really great.
It is, because when at baseline, when we're doing your first skin check, we are trying to predict the biology of every lesion on your body. Yeah. And that actually we can only really assess biology over time. That if a lesion is stable over time, that means pretty much that it's benign, but we need time to see that. So the digital dermoscopy suite, where we can take the pictures and look at them again later on, allows us to see how the lesion is behaving, which is wonderful.
And I often think this is one of the key reasons to go see someone that knows what they're doing, because every year, Dr. Anne, you and I will diagnose a handful of spots that are, we might diagnose, somewhere between 100 to 150 cancers each year, some years more, some years a little less. and that's each of us. And
Mm-hmm.
each year, each one of us will do maybe 3 or 4 skin cancers that are less than 3 mil in size. And
Yeah.
those ones that are less than 3 mil in size, you'd never be able to pick them without some version of a digital dermatoscope. You'd often have to wait until they got a bit bigger so you can see what the details look like, with the handheld dermatoscope. So I think it is a very valuable addition to the toolkit.
Yeah. So when we're checking your skin, we will actually look at pretty much every single lesion on your body, which for some people ends up being rather a large number of lesions. And while we're doing that, because spots is not always easy to tell. You cannot always tell with the naked eye that something is a worry. So you have to put your dermatoscope on to know for sure. But whilst we're doing that, we're also doing what we call the comparative approach, where we are comparing all your moles with everything else on your body. Because particularly with someone who has a lot of moles, you will usually find they'll maybe get half a dozen or less types of moles on their body, and that they will have several of each variant. And if that's not the case, if there's one that's a standout because it's an entirely different pattern from the others, then that will often be the one that's actually of concern. And that's not
And there's a
something that you can
couple of
learn in a
cute
book.
words for that, aren't there? Or a couple of cute names for those, aren't there, Dr. Anne? What do we call them?
Well, it depends at what point it looks different. So ugly duckling is with the naked eye different, which is what we ask patients to look out for themselves. But there's another cute little, what they call it, the little Red Riding Hood sign. Which actually is probably a silly name for it, but I'll explain why. So Little Red Riding Hood looks like all your other moles with the naked eye, looks entirely innocent. But once we put the dermatoscope on it, it has clear clues to being a nasty thing. It should probably be called the Big Bad Wolf rather than Little Red Riding Hood, but here we are. That's what it's called.
Mm-hmm.
I didn't get to make up the names, so that's where we are. The other thing that we will take notice of is that if a lesion appears to be lonely. And here we're usually talking about pigmented lesions. But if you've got particular area that's not exposed much to the sun, so a large area of white thigh, and it's got a startlingly dark lesion, just one sitting on the skin, then that would be a lonely lesion, occasionally called priest in the snow. But
Mm-hmm.
that again would draw our attention. It doesn't mean it's nasty. Sometimes you can just have a boring old seborrheic keratosis, but it definitely draws our attention, and we'll have a careful.
Absolutely. And these are all things that patients can keep an eye out for as well, in terms of something that looks really different compared to the other moles with the naked eye, like you've said, or something that's all by its lonesome. The patients probably can't find, Little Red Riding Hood, the big bad wolf in grandma's clothing, but you can certainly pay attention for all those other features.
Yeah.
Very good, excellent. So yeah, we found the ugly duckling, or we found the priest in the snow. Where to from there, Dr. Anne? What are we sort of having a chat about once we've put our dermatoscope on and decided that this thing is slightly odd rather than obviously cancerous?
So if it's slightly odd, we then talk to our patient about what they would like to do about that. Although actually, before we're talking to our patient, we have to do a little run through our own internal checklist. So our internal checklist would be: is this lesion already large? Is this
Mm-hmm.
lesion already thick? Or interestingly, does it have a pattern of globules? Now, if the lesion is large or thick and it's a melanoma, then monitoring it makes no sense at all.
Mm-hmm.
The globular pattern, it just means that the pigment's forming little oval structures, and that's associated with faster growth, and it's sort of a soft rule that you probably are best not to monitor lesions of that pattern, because they're likely to be faster growing, possibly more
Yeah.
aggressive. So we would first do an internal check to see, would it be awfully silly to monitor this lesion if it is a melanoma? So basically, if it's small and flat, and ideally has what we call a reticular pattern, which is like an open network, then the international accepted guidance is that it's safe to monitor that lesion. I guess we need to talk about what the hell safe means. Do you want to
Mm.
take that, or shall I carry on, Moz?
No, so I know. Carry on, carry on. I think
Okay.
you'll cover that well. Go for it.
So safe means that its prognosis will not change if we delay a few months and it is indeed a melanoma. So if it's a small flat melanoma, it will still be a small flat melanoma which hasn't invaded 3 months down the line. If there's any
Mm.
possibility that will transform to an invasive melanoma in the time, then we should not be monitoring it. And this is not just the world according to Moz and Anne. The sort of 3-month review is kind of international standard from well-respected experts.
And again, I feel like we say this every single podcast. We're good at predicting populations. We cannot predict individuals. So we're just trying to basically guess if we're wrong and it is a melanoma, will something bad happen to you in that next 3 months? And if it's already big and already thick, and if it already has high risk features, then it's a terrible idea. If it doesn't have any of those things, then we think it might be okay to watch it for the next 3 months, but there are still no guarantees. And so I guess that's part of the next conversation that we all have, isn't it, Dr. Anne? So, sometimes we're trying to decide if it's an absolute no-go to monitor.
But you definitely have input in this. If we think that it's reason or not unreasonable to monitor the lesion, we will have a chat to you. And patients' tolerance of risk, it varies person to person. There's not a right way to be. There's how you are. And you're weighing up the possibility of an unnecessary biopsy, which leaves you with a scar on your skin. And it carries the risk of any surgical procedure of infection, ugly scar, nerve damage, all the bad things that can happen with the biopsy, against the possibility of leaving a small cancer on your skin for a little while. So if you have one lesion of borderline concern, it absolutely is your decision what we do with it. If it's safe to monitor, you can still say you prefer us to biopsy it. And people often do just want us to biopsy it because they can't be bothered with the coming back and forward and the uncertainty. If, however, there are 4 or 5 lesions that we regard as borderline, then that is a real indication to monitor, because it is super unlikely that 4 or 5 of these fall off my seat if all 5 would be melanoma. And it's just a suggestion that your body makes slightly weird looking pigmented lesions, and that in that situation we would be strongly recommending follow-up. I would not actually be willing to biopsy all 5 of those lesions. What about you, Dr. Moz?
No, yeah, absolutely. And that's a thing that, ultimately it comes down to the patient and the patient's preference. And our job is to give advice and information. But often, we'll see that a lot in, less experienced skin cancer doctors, where they might remove 6 or 7 things and you find that all 6 or 7 are not a cancer, at which point you sort of go, well, that was a pretty good reason that we should have been monitoring these spots. For that reason that Dr. Anne has said, it's extremely unlikely that you're going to have 6 or 7 brand new melanomas in the space of a short period of time on you. But obviously we respect that the human body's a weird and interesting beast, and sometimes doesn't behave the way we think it should, and that everyone's circumstance is different. I've definitely removed over the years more than one thing because the patient has preferred that that's the case. But as a general rule, that's probably a good reason, like you said, Dr. Anne, to keep an eye on things rather than cut them out.
And to be clear, we're talking about pigmented lesions here. It's actually far from unusual for me to finish a skin check, I think for yourself as well, and find that there are 4 or 5 lesions that I want to biopsy. But those will tend to be lesions that are suspicious for non-melanoma skin cancer. And for patients who have non-melanoma skin cancer, it is not unusual at all for them to have 3 or 4 at a time, particularly if it's the first time we've seen you. So sometimes I'll biopsy 6 things, but 5 of them will turn out to be a cancer. So when we were saying that half a dozen biopsies are unreasonable, we are talking half a dozen biopsies of pigmented lesions.
Yep, because it's much rarer. And much like you, Dr. Anne, just last week, I think I had 3 or 4 patients where I've biopsied 5 or 6 things, but much like you've said, almost all of them have come back as some version of non-melanoma skin cancer. So yeah, I think again, it comes down to sort of a patient-centered decision. But I guess we just wanted to empower people to have that conversation, feeling a little bit more confident that they sort of know a little bit what they should be expecting out of their doctor.
Yeah. So basically, our essential tool is our dermatoscope. Dermatoscope plus appropriate training is incredibly important, but this is what allows us to diagnose suspicious spots. The digital dermatoscope allows us to store photographs and do interval reviews that are actually meaningful, as opposed to relying on my memory of what it might have looked like last time.
So maybe that's an excellent segue to talk about who should be doing your skin cancer check, Dr. Anne, because we obviously can't skin check everyone in Melbourne. There will be people, or actually around Australia, where hopefully lots of people are listening to the podcast. But so let's say you're trying to decide who should be doing your skin cancer check. What's a good way to decide that?
good way to decide that. Obviously, you can see a dermatologist. Good luck getting
Hmm.
in. There are not a dermatologist can possibly do all the skin checks that are required in Australia, but also a dermatologist completely knows what they're doing. And if you have someone you want to see, wonderful. But for the vast majority of people, they can't get to see a dermatologist either on cost basis or just lack of availability. So then you're looking at choosing a GP or a skin cancer doctor. And one of the wonderful things about being a general practitioner is that everything is your department. Like
Hmm.
as a general practitioner, you will give an initial opinion on just about everything that medicine can throw at the human body.
Hmm.
But some of us have training in skin cancer and some of us don't. And our certainly recommendation would be that you choose wisely and choose a general practitioner who has had at least basic training in skin cancer detection, who is actually proficient in the use of our lovely little dermatoscope. Unfortunately, there is a way to help the population find someone who has completed satisfactory training, isn't there, Dr. Moz?
Absolutely. So I guess before I will keep that dangling for one or two more
Will you?
sentences,
Okay.
which is essentially that the term skin cancer doctor is not protected, and there needs to be some version of quality control. So, as Dr. Ann has said, our dermatologist colleagues all have had excellent quality control in earning the title of dermatologist. So we know that they're very good at doing what they do. But there's, as Anne has highlighted, sometimes some access issues around them, especially for routine skin checks. I think if you decide overnight as a GP that all of a sudden all you want to do is skin cancer work, but you have zero training, then there is nothing stopping you from calling yourself a skin cancer doctor or a doctor with an interest in skin cancer. And so I think as a patient, what you want to do is you want to have a little look and see what it is that they have done that has earned them the right to call themselves a skin cancer doctor. And so I think what Dr. Ann was alluding to is probably one of the biggest training providers of skin cancer education in Australia for general practice is and New Zealand as well, I think actually, is the Skin Cancer College of Australasia. And so they've got a website where we'll probably post a link in the show notes that lets you know if your skin cancer doctor is accredited. And people who are accredited, Dr. Ann, refresh my memory because it's been ages since we were accredited, so I can't actually remember what we had to do. I think it was a minimum of 1 or 2 years plus an exam. Is that right?
2 years plus an exam, and we had
Yeah.
done our master's degree at University of Queensland. But even with our master's degree, they not incorrectly required two things from us. We had to sit and pass their exam, and we
Hmm.
also had to submit a logbook, both showing our diagnostic skills and showing our surgical skills. Yeah. Most skin cancer doctors both diagnose and operate, so both of these things are important.
Yeah, absolutely. And I think the key thing is not to be shy about asking for these things because I think it is important, isn't it,
Yeah.
Dr. Ann? Like I think we are talking with very important diagnoses, so you don't want to get them wrong.
Absolutely. And just having a dermatoscope, obviously, if you go for a skin check and the doctor doesn't have one of these, then you should be very concerned. But just possessing one is not enough. They actually have to have training that the studies have shown that having a dermatoscope but not having a clue what you're looking at actually worsens diagnostic accuracy because the view through the dermatoscope is very different from the view from naked eye. You will see from the pictures that we post. And if you have no clue what you're looking at, then it all just looks weird. Or
Mm,
pretty.
yeah.
Sometimes it looks pretty. We'll show you some pretty pictures too.
We'll try and share some pretty pictures. Although I think the pictures are at the start. Maybe we'll throw some more pictures here just for fun. So
Yeah,
now
maybe we
that
can do
we've made mention of
some pretty
pictures,
pictures of benign things like hemangiomas. Yeah, we'll find
yeah,
some pretty pictures. Yeah,
yeah,
I show the patients the
absolutely,
pretty
yes,
pictures as well because I think they're fascinating. Yeah.
very good, excellent. All right, and so before we wrap it up for the day, Dr. Ann, we have covered a lot of ground. Is there anything people should think about from a practicality perspective about, turning up on the day for a skin check? Is there anything that they can do to make our life a little bit easier and
Oh
make sure
yes,
we diagnose
please.
their skin cancers?
Yeah, we would love you to come with clean skin, so that would be no makeup, no fake tan, and no nail varnish. Be prepared to remove your jewellery, maybe even leave it at home if that's an option.
Hmm.
And as we touched on earlier, think about your undies. That the Bridget Jones undies don't really work for us when we're trying to look at your skin. The other thing
Maybe
is
we'll have a
that
photo of those too.
I think everyone knows what Bridget Jones' undies look like. The other thing to say is that be prepared to let us look in the areas where the sun doesn't shine. When it comes to the genital area, we will usually simply ask you if there is anything concerning you. And it's really good if you can have had a look before you come. We are very happy to examine it, but many patients are not so happy to be examined. But that means somebody has to look, and if it's not going to be us, it needs to be you then. Certainly in my practice, I had changed after doing my sort of vulval workshop last year. And for women after menopause, I actually encourage and say that my preference is to actually take off their undies and check their genital area skin, because vulval melanoma is rare, but it's not sun associated, and it tends to happen in women after the menopause. So it is my preference to check that area, although of course you can say no. What else would we like you to do? We would like you to be ready to answer questions on your skin cancer risk. So if you can have a think about all of the things from significant sunburns to solarium use. And if you've had a cancer before, we would love you to have the details of that. If you've got the pathology report, we'll be kissing your feet, But we would like to know all of those things, and the same for family history, like if you know who's had it, what age they've had it, and whether ideally it was a melanoma or not a melanoma.
I don't think I've got anything to add to that, Dr. Anne. You've covered all the good bits.
When we wind up our skin check, we'll also give you our opinion on your future risk of skin cancer. And we will also almost always have a little chat about UV radiation and how to protect yourself from the sun.
Excellent. Well, if there is nothing else to add from you, Dr. Anne, maybe what we'll do is we'll thank everyone for joining us for this third episode. If you've made it this far, we thank you greatly. This one is also a good episode, we think, to watch online as well, because of all the photos that we'll have added. I think if you have enjoyed the podcast, give it a thumbs up, give it that 5-star rating, and share it with someone that you think might benefit with from the information. As always, Dr. Anne, thank you very much for your time. Much appreciated.
And thanks for yours, Dr. Moz. We'll see you next week. Bye.
See you next week. Ciao.